Welcome, everyone. I am Rachel Wall. I am the CEO and founder of Inspired Hygiene. And I'm super excited that you all are here with us tonight. We've got a really great, I think, a hot topic in reducing periodontal therapy denials. So I want to introduce Jennifer Stedman, our Director of Operations. She's going to be chiming in as well. Let's go ahead and get started. Um, so the agenda for tonight is we're going to talk about some common mistakes we see when submitting claims for reimbursement for scaling and root planing. We're going to talk about the requirements for diagnostic documentation, how to have proactive patient communication, and what are a few things you could include for effective appeal when you do get a denial. And then we'd love to just hear you all share your experiences too, things that have worked for you. Certainly, we are really fortunate to have the insight into a lot of different practices, but we don't know everything. We don't have every answer, but together we do, right? Together we have lots of solutions and questions and things to this. So we would love to hear from you guys as well. We want this to be interactive. So these are just some images of some of our client teams that we have had the privilege of working with over the years. And I always love sharing photos like this because it really warms my heart when I just think about not only the impact on all of these clinicians and business team members, but also the trickle down effect of the impact on all of their patients, right? Because when we know better, we do better. And our whole goal with Inspired Hygiene is to help you all elevate your hygiene systems, the care that patients are providing, and that just trickles down and ultimately helps improve business outcomes as well. I wanted to start by just talking a little bit about belief systems and everything that we do. In fact, I was talking with a dentist today, a potential client, and they asked, is your program really focused on systems and protocols? And I said, well, it is. However, just dropping systems and protocols into a practice or into a team culture does not ensure that those are going to be effective, right? It does not ensure that they're going to even be implemented. And really, the biggest piece of it is shifting the mindset. So really, one of our goals is really to help teams, particularly the hygienists, but it takes everybody to really shift their mindset around the value, their belief in the value of the care that they provide. And this is not, there's nowhere that this is more true, in my opinion, for hygienists than in the periodontal space, just based on what we work on with clients. Like I would say 99.9% of our clients, the first thing that they want to address is help us get calibrated and help us develop a really clear process for diagnosing, enrolling, and treating our patients that have active disease. So the first step in any of those systems and protocols being effective is making sure that we believe in the care that we're presenting to patients, and that we believe that the value of that care is not only, protecting our patients' teeth and their, reducing the amount of bone that they're losing and just their general oral health, but it also the value of is involved with their overall health, right? What are we helping them reduce their risk for? Are we helping reduce the risk for type 2 diabetes? Are we helping reduce the risk of cardiovascular disease, stroke, heart attacks? That the value of that is really immeasurable. And so the way that we want to approach this as it's related to periodontal therapy claims is, really having that belief that the clinical team's role is to identify, what looks great, what looks healthy with the patient, and what doesn't, and when it's time to intervene and recommend therapy. And I'll say in our industry, I've said this before on these virtual growth forums, and, don't shoot the messenger, but it's true. It's very often we say, well, insurance doesn't drive our treatment. We're not insurance driven. Insurance doesn't determine what we recommend to our patients. And I'm going to call BS on that if I might be so bold. In a lot of cases, because we see this, we hear this, we're teaching, and then a team member will say, well, we can't recommend that because their insurance doesn't cover it. That's the exact definition of allowing insurance to dictate treatment. But even it even is true when maybe we're going through the benefits that our patients have, and we're talking about that at huddle, and we're saying, hey, you know what? Um, I know that this patient has had scaling and root planing and they should be a periodontal maintenance, but they only get benefits for those twice a year. And so let's just convert this to a pro fee. That's allowing insurance to dictate treatment. So I would just say, think about that and really work on your mindset around, do we really believe that we can recommend the best care and that we can really approach their benefits as just that, right? This is a benefit. Now, I know that in some practices that's easier than others, right? If you are a fee for service practice where you accept insurance and you file that for the patient, but you're not in network, it is well, I say in my mind, it is a bit easier, but I've always surprised sometimes when we work with fee for service practices that still have that same mindset. They're like, oh my gosh, my patients won't pay for that because it's not, 100%, there's not 100% benefit to cover the cost of that. I'm like, hang on a second. Like this is the same practice where patients are, completing a $30,000 full mouth rehab. So how about we don't make decisions for our patients and their healthcare? We let them do that. So that's essentially what I'm saying. So just I just always have to address that mindset piece before we get into the nitty gritty of the systems, because it really is a critical piece, and it can really be a block to us really achieving that role of healthcare provider and really continually seeing our hygiene department evolve in that manner. And it also can be a block for our patients, because here's the thing: the patients won't believe in the value of the treatment until the clinician does, right? Until the business team does. They're looking to you, right? They're following your lead. So if it's something that you say, gosh, this is really expensive, they're going to feel like it's really expensive. But if you come across confidently and say, you know what, I see on your medical history that you have a family history of diabetes. And here's the thing: you have this active infection, and that's going to increase your risk of type 2 diabetes. So I know you shared with me that you're concerned about your health. Let's address this together and help reduce and eliminate this active infection. It's going to reduce your risk. So just really being their champion and having that mindset of a healthcare provider, I think, is super, super important and critical in this piece. All right. Jennifer, chime in if there's anything that you want to add at any time.
Do.
I would encourage our coaches to do the same. So here's some of the common mistakes that we see. And here's what I'll also say is, certainly, uh, things have gotten tighter, and we have to really dot our I's and cross our T's in a much more careful way than we have in the past with regards to insurance and patients receiving benefits for the treatment that we've provided. Okay, so there's no secret. Yes, it has gotten difficult, and we have to be more careful with that. What I will also say is that a minimum of 50% of the time, when our clients say, hey, we're getting these denials, and we say, let us look at these cases, 50% of the time there is a critical piece of diagnostic information that is missing. So just I would say, look at that first, right? What is missing? What could we have done differently? What information could we provide that would maybe have avoided this denial, or it will help us have a successful appeal? So these are the common mistakes that we see. Radiographs not of diagnostic quality. Okay, we'll go into that. We're going to go into all of these and what the solution is to this here in just a minute. Medical history not current, or I would say not utilizing the information in the medical history to support the treatment that you have recommended and completed for this patient. Periodontal charting is either partially complete or not complete at all. Um, Undiagnosed periodontal disease. So you're thinking, well, if it's undiagnosed, would I be submitting a periodontal therapy claim? But here's what we sometimes see is that maybe one area was treated, but there's undiagnosed disease in other areas that were not treated. And so if we had shown the full extent of the disease, it would have given more support for the treatment that was rendered. Um, no treatment plan, right? So obviously, not having the procedures in the treatment plan or not having a complete treatment plan is a common mistake. And then documentation discrepancies. So I would say this is more, um, I would say uh, uh, documentation, incomplete documentation, right? Things that are left out of the clinical notes. Or maybe there are discrepancies between the clinical chart and what is documented in the clinical note. So let's talk about a few of those things.
Hey, Rachel, we're getting in the chat here that we have a few attendees that are here tonight that have had issues with claims because they don't put the time, the length of time, and how much anesthesia was used. So that's really
Mm-hmm.
important, especially with what you were just talking about, right? Making sure that your notes match what you have submitted to the insurance too, making sure
Yeah.
everything, there's no discrepancies there and that you're including everything in that claim form.
Yep. That's a really great point. I'm glad you brought up the time because that's one that is becoming more and more often requested. And I think the reason for that is insurance companies are making sure that, we're not trying to, do 4 quadrants in an hour, which, you know, I think we're bordering on the insurance companies dictating how we're treating our patients. Like, we all agree on that, but that is something that is often requested. So thank you for mentioning that. So this is just to set some context here, and I want to set the tone too. All of you that are working in dental practices, and us too at Inspired Hygiene, we think of our clients as, um, above average dental teams, right? You probably think that way about yourself, or you might think, well, we're like every other dental practice, but you're not, right? Those practices that engage with a consultant are in the top 10, 20% of dental practices from a standpoint of the health of their business, very often their production levels, their perio percentage, and all of those things. And you all are probably the same because you're attending this webinar, right? You are wanting to learn more, you're wanting to solve some of these issues. So the reason I bring that up is because these stats are from clients that we work with, and they are again in the top 20%. So imagine for those clients that are not in the top 10 to 20%, what their data may reveal. So over the course of 3 years, right? So this is since 2021, Inspired Hygiene has audited almost 1,400 patient charts. We do this as part of our hygiene growth roadmap. The Hygiene Growth Roadmap is a detailed analysis of the hygiene department. And we look to see what looks really great, what is being done very well, and where are there opportunities to refine and build on what you're already doing, right? And a chart audit is always critical. In fact, I encourage all of you to put this into your regular, just, self audit system. Once a quarter, a couple times a year, do a chart audit. And are you guys still, are you doing what you said you were going to do in your standard of care? And we're going to get to that in just a second. So, okay. So almost 1,400 charts. Here's what we've seen. 73% of those charts had a completed medical history within the last 2 years. That's actually a pretty good number. Like, obviously 100% is the goal, but that's not very realistic. 73% is actually pretty good. And then here's where it gets kind of like a wake up call, right? 51% of the radiographs of the charts, 51% of the charts, the most current radiographs were of diagnostic quality. So only 50% of the most current radiographs, so let's say the bite wings that were taken in the last year or the FMX, were of diagnostic quality. And now diagnostic quality is defined by an insurance company, means there are no cone cuts, that if it's a bite wing, that we can see the bone level on the maxillary and the mandibular, that the contacts are open in the desired area. If it's a periapical, that we can actually see the apex. So only about 50% of those x-rays were of diagnostic quality. Only 37% had all pocket depths charted. Now we know, and we're going to review this, that pocket depths alone does not make a complete periodontal chart, correct? But that's one of the things that we can look at, right? Because we don't know when we're auditing a chart, did this patient have recession, unless there's a digital scan or we can see it on a radiograph. So that's a difficult thing for us to judge, right? But we know that if we're doing a screening periodontal charting, right, that there should be all pocket depths recorded. Only 37% of these charts had all pocket depths charted within the last year. Uh, 44% of those charts had bleeding noted in the chart, but it wasn't charted on the perio chart. Okay. And then 63% putting together the radiographs, any notes or charting of bleeding, and pocket depths, right? And recession if it's present. 63% had what we believe to be obvious periodontal disease. Obviously, we didn't see the patient. We're just looking at the chart. And out of that 63%, only 60% of those didn't have a treatment plan for periotherapy. So therein lies the opportunity, right? If there is periodontal disease obviously present in the practice, which every practice has it right now, it is true that there are some demographics that are different than others. I spoke to a doctor in Boulder recently, and he's like, "Look, we're actually voted the healthiest city in the United States." I'm like, "Okay, so yeah, you probably do have healthier patients, but within reason, right? So if you're looking at your perio percentage and you're at 10%, likely there are more than 10% of your patients that have active disease. Okay. So this just demonstrates that, right? There's always room to refine things and improve our documentation. All right, so I mentioned standard of care. So this is a tool that you can get this on our website. If you go to our website and you go to resource guides, you can download the standard of care there. This is a worksheet that you can use to work with your team to really establish these written, consistent standards of care between all of your hygienists. You could use this, to also establish your clinical restorative standards of care if you wanted to. But this is to get you started. And what I was saying earlier was, spend some time on this. Really talk about what do we believe is the correct interval for our patients with regards to radiographs. How often are we going to complete a periodontal evaluation and charting? And, what about medical histories? How often are we going to have the patients complete and sign a full new health history questionnaire? So get all this in writing so that everybody knows and you're all on the same page. Because otherwise, you may have had a conversation during a team meeting and one person thinks we're doing this every 2 years and somebody else says, well, I thought we were doing it once a year. So this is a really good exercise. You could take one chunk of this and do this, at a team meeting every couple weeks and really work through this. And then what you do is you do those chart audits and measure and say, okay, so is what we're collecting matching up to our standard of care? And here's the thing, this is not an effort to like criticize anybody or call anyone out or make anybody feel wrong. This is an effort to elevate your standard of care so that your patients are getting consistent treatment, right? That continuity of care between providers, and that you are also protecting your practice, your providers, and your patients by having this critical documentation. So encourage you to go check out the standard of care. It's a great resource, and a really great way to create those standards for your practice. All right. So many of you probably know Dr. Roy Shelburne. Dr. Shelburne is a dentist, and man, for a while there, he was one of dentistry's busiest speakers. Unfortunately, actually, the day that I met Dr. Shelburne, I will never forget it. We were both attending the Speaking Consulting Network. It was about 13 or 14 years ago. And I had been a member of the Speaking Consulting Network for, maybe 4 or 5 years at that point. Dr. Shelburne sat right next to me and introduced himself. He was a newbie, as we called him, and it was small enough at that time. We all would stand up and introduce ourselves, right? So it got to be his point. He stood up and he said, 3 days ago, I was released from federal prison. And he had been in federal prison for 2 years. For having essentially record keeping mistakes, and he and his team not catching those mistakes. and it resulted in a charge of Medicaid fraud. And because he was a Medicaid provider, it was a federal offense. And he then was there to really pull out of a really dark place and rebuild his career. And his mission was to help keep that ever from ever happening to any other dentists. And so he speaks on this. I would encourage you, those of you that have study clubs or you want to have a phenomenal speaker, he is incredible. And so I always love to use this quote, which he says is not having a system to identify and correct record keeping mistakes is considered intent to defraud. And you can be held accountable for that. And it's not just the dentist who can be held accountable. So diagnostic documentation is a requirement. I was telling a story this past week about my first dental hygiene job in 1991. And, we were still using those little ledger cards, and the clinical notes consisted of about 6 letters, right? Um, PRO, or maybe 5 letters, PROEX, right? Prophy exam. And that was the extent of the clinical note. But that's not good enough anymore, right? We've got to really, really be detailed, and we're beginning to be held to the same standards as the medical community, and we're going to see more and more of the medical industry's requirements for diagnosis codes, and things like that coming into dentistry in the coming years. Okay, so again, medical history is required, radiographs and images, periodontal evaluation, screenings, comprehensive clinical notes, documentation of all of these things, okay, is really, really critical. For those of you that were with us, I believe it was the last growth forum in March, we talked about risk, reducing your risk, and it was all about documentation. Okay, so here's our recommendation. Let's start with we talked about the mistakes. So like, what are the solutions? What are the ways that we can avoid those mistakes? One is make sure that every patient completes a questionnaire and signs every 2 years. Okay. Completes a medical history questionnaire, signs every 2 years, and then you're updating the medical history at every visit, right? That is the tell me, and I'll let's talk about some open-ended questions. So drop in the chat if you would. How do you usually ask the patients about changes in their medical history? I'd love to hear if anybody has any cool, unique ways, or maybe it's a really simple way. How do you ask your patient, have have they had any changes in their medical history? Let's just see. Any new diagnosis, surgeries, or medications. I love that's very specific, right? Because how often have we, a patient said no, and then the dentist comes in and they're like, "Oh yeah, I had a heart attack 6 months ago," and like we have a heart attack, right? We're like, "Oh my gosh, what's happening?" Our hygienist says, "Any recent hospitalization changes since your last visit? Any changes to your health? Any new medications? I'd like to review your overall health and medication since I saw you last." Okay, I want to point that one out, because this is actually not even a question. It's a statement, which I love. And here's what I would say is, see how you can turn your questions into an open-ended question or a statement. Because even if we ask things specific, like, have you had any new diagnosis, surgeries, or medications? Once they say no, it kind of shuts the door, right? So I love that. I'd like to review with you your medications and any changes in your medical history since the last time you were here. Emmy, one of our coaches, says, tell me about tell me about your last visit with your medical doctor, right? That's going to be really telling. Because if they say, oh my gosh, I don't even remember the last time I saw my doctor, that's a red flag, right? Or if they say, you know what, actually, I'm pre-diabetic. They did some testing and I'm pre-diabetic. And then, you guys are so great. I know I love hearing this, and I know most of you probably do this, really reviewing those medications. So here's what the medications you were on last time. Can you take a look at this? Can you review this for me and make sure it's the same? Let me know of any differences here. So just using those like open-ended questions. I love that. Yeah, if they haven't been to the dentist in a while, they probably haven't been to their doctor as well. I would completely agree with that. Right, which is all the more reason for us to do those screenings, right? The blood pressure and oral cancer screenings and all of that, because well, medical doctors don't are not going to be doing an oral cancer screening most of the time. So they're really relying on us. All right. Any comments or questions about medical history? All right, good deal. All right, let's talk about radiographs. Okay, so I will say there is a high percentage of the time when we are reviewing a case for one of our clients that was denied that the radiographs look similar to this one on the left. And what do you notice about this radiograph on the left? What's something that stands out for you? Just drop it in the chat if you would. What stands out for you about the radiograph on the left? Yeah. Lee, you got it right. No mandibular bone level is visible. Okay. And so what we see very often is that just is an automatic denial, right? If they cannot see the bone level, then where is our evidence? All of this that we're reviewing with you guys tonight, the whole point is you have to prove your case, right? You've got to prove your case to yourself first, right? Does this patient have active periodontal disease? And are we moving this patient into therapy, right? You've got to prove your case, medical history, your radiograph. We recommend vertical bite wings. My most recent career, probably for the last, I'm going to say 20 years, we only took vertical bite wings on adults. Unless there was just no way that we could do it. They had a very small, restrictive mouth. We did vertical bite wings just across the board. So we can see so much more. And so that's the first thing I would have you look at. If you have some that appeals, is look at the radiographs that were submitted with that claim. Can you see enough of the bone level? Now, you can see here on on the maxilla, on the one on the left, and on both arches on the vertical bite wing, I can see plenty of bone. You need to be able to see enough of that bone for them to make a judgment, okay? I want to go back just for a second, and I want to talk about medical history too. Um, One of the reasons why it's so critical for us to have a current medical history is so that you know if there are any risk factors that, number one, could result in rapid progression of periodontal disease, right? Diabetes, smoking, rheumatoid arthritis, like the list goes on and on. Okay, so that's number one. And then number two, are there any risk factors combined with periodontal disease that increase the patient's risk for more serious health consequences, right? Like heart attack, stroke, things like that. So, have they been diagnosed with high blood pressure? Have they been diagnosed with type 2 diabetes? Have they been diagnosed with an autoimmune condition? There's a number of things there. So, there's a plan, right, of all of this coming together. Okay, next mistake that we often see is something like this, where maybe the pocket depths have been recorded, but there's no bleeding recorded. And right, bleeding is our sign of active infection. So if we've moved patients into active therapy, then there needed to be bleeding in order to make that judgment. And if we're submitting something like this and there's no bleeding, then that patient doesn't have active disease or there's no signs of active disease. Now, you could make the argument about smokers, right? But that's an exception. So if we're submitting a periodontal charting and there's recession present and we're not recording it, then we're missing a huge piece to show attachment loss. If we're submitting a periodontal chart and there's no bleeding charted, then why would the insurance company provide treatment for active disease when you've not shown that there's evidence of that? So just really evaluate your periodontal charting. Now, the one on the left, obviously, you can see that there's recession charted, there's bleeding charted, there's furcation charted, there's all of those things are charted, right? So really make sure that we're including this complete periodontal evaluation. And again, we go back to that medical and dental history, right? Does this patient have a history of periodontal disease in the past? Do they have some risk factors like I just mentioned? Do we have diagnostic radiographs? This is everything that we need to be able to provide. Okay. Periodontal charting should include all of these things if they are present, right? If there's mobility, we must chart it. If there's furcation involvement, we must chart it. Um, Images to show inflammation. It's pretty hard to argue, right, with this image. And then also if we have any pathogen testing results, those are really important to provide as well, because it just shows high levels of periodontal pathogens, and you can also tie that back into the risk factors there as well. So if you want to take a screenshot of this, this is what you want to be sure is included in your complete periodontal evaluation. And then clinical notes. The clinical note needs to include the diagnosis. And remember, staging and grading is the disease classification. The diagnosis comes before that. So a diagnosis is that the patient has, they have active periodontal disease. So you want to make sure that you have that diagnosis in there. I would include the staging and grading as well for completion. I don't believe that insurance companies utilize that, although I would say you could make your case if they're a grade C, because likely they have diabetes and or they are a smoker, or you're seeing a lot of destruction and very little hard or soft deposits, right? Those are some of the modifiers to move a patient from a grade B up to a C. So I think including staging and grading also is important here. Again, their medical risk factors, correlations, treatment rendered. So what did you actually do? What is the treatment that was recommended? What is patient concerns? Any other recommendations that are there? And here's the thing, when you include the medical risk factors and correlations in your clinical notes, you're really helping make it easy for your business team. It's not your business team's role to have to dig through the medical history and like connect all these dots, right? The clinicians, that's our space, and we can do that so much more easily because that's our focus. So include that in the clinical note, and then the business team can just attach the clinical note. Now, what we're hearing, and yeah, I see this. Delta told us they have no interest in staging and grading in our notes, but we still add it. I think that's good, and I've read that as well about other insurance companies as well. But I think it's still good to include it, if anything, for your own documentation, right? You wanna document the classification. Um, Jennifer, I've heard from multiple sources that insurance companies are no longer interested in a long narrative with the initial claim, but rather including critical points, like attaching the clinical note and including critical points in the note on the claim. Do you have any input? Can you give any input on that?
Yeah, I have heard the same exact thing. Teresa Duncan had said that, like they want to make sure that it's not just a narrative that we write after the fact. It's physically what is in their note, and that everything that's in that patient's chart matches exactly what you have submitted to them.
Yeah, very good.
And they will ask you for a screenshot of the chart if you're going through an audit or anything like that too. So just make sure that, you are including the exact patient note in there. Yeah. Makes it
Yeah,
so much easier for your business team too. You're 1,000% right on that.
yeah. So I'm looking at the chat over here, and I see that you've gotten some feedback about intro photos. Personally, I would include them, or still at least take them. And if they don't want them, if you have to do an appeal, you can pull them out. So I would default that to an insurance expert whether or not to attach those. But I think they're super valuable because sometimes they do show recession and attachment loss and active inflammation. Yeah, I love intro photos as well. I mean, they're hard to argue with. Okay. All right, proactive patient communication. So Jennifer, I know I've got some thoughts about this, but I'd love for you to share your thoughts. I can chime in, but can you kind of take over here?
Yeah, absolutely. So it's really important, just, similar to what we do on the clinical side with a patient, right? We're always informing them, we're communicating everything that we're going to be, doing and working on with them. We also want to do that on the insurance side. right? On the business side, we want to make sure that they understand what we're going to be doing, like processing their insurance on their behalf, and really just make sure that they understand a huge thing, right? That dental insurance is not like their traditional insurance. It's not like your homeowner's insurance or your medical insurance, right? If something's broken, it doesn't mean that it's going to get paid for and get fixed, right? So it's really important that they understand that and know that you are doing everything in your power to maximize the benefits that they have available to them. Recently, I attended a course with Teresa Duncan, and one of the things that she had said was to ask the patient to supply their coverage, their certificate of coverage from their insurance that they can get from their employer or get from their insurance company. It's a 25 to 30-page document. It is long, it is extensive. It goes into a lot more detail. Obviously, we know that on the admin side, that anything that you're going to pull up on a website or doing insurance verification, it gets down to the nitty-gritty of everything. And really going through that and letting the patient also see the extent of that document just allows them to realize too, okay, this is a whole lot more than what they're thinking that it
Yeah.
is, right? But having that resource to go back to and also identify what is included in their plan that their employer has chosen, right? We know that that's how dental insurance works.
Mhm.
It's not one size fits all. Just because one business on business A has Delta doesn't mean that business two's Delta is the same plan. So really
Right.
making sure that they understand that from the beginning, and just so that they know again that we're doing everything in our power to get the maximum benefit for them that they have
Yeah.
available.
Yeah. Thank you for that. And the other thing that I always like to express is being open about expectations and patient responsibilities. We always teach, instead of using the term cover, use the term benefit or contribute, right? So really being sure that your language is and the words you use are consistent with the message you're trying to convey, right? So if we're telling our patient, this is not like dental insurance, and then we say, well, they're going to pay for all of this or they're not going to pay for that, then it's a little bit um, it might be a little confusing. Instead, you could say this is a benefit, and your dental insurance will contribute to your dental care, your dental care fees. Typically, it doesn't cover all of your care, but it does contribute. And so I always feel like it's appropriate to just be really open with them, especially when you have a patient and you want to start treatment earlier rather than later, right? You want to be proactive because the treatment is less extensive and it's less expensive when we catch disease early. And by the way, it prevents the patient from walking around with that chronic infection for another, number of years and losing more bone and all of that. But when we're sitting down with them and saying, okay, here's the plan, right? That, um, Jennifer, your hygienist, and, Dr. Smith have recommended for you. And they feel very strongly that this is in your best interest because of this active infection. Here's what we have projected for you. This is an estimate, and it could go, you could expect one of two responses from your insurance company. One is that they will provide, right, this level of benefit or close to this, and this would be your portion. The other way they might respond is that they're not going to provide a benefit, and this would be your portion. Either way, this treatment is necessary to stop the progression of this disease. And it's up to you, your choice, and we can help you work out your responsibility. We've got these three options here. So you're laying that expectation for the patient and we're going to do everything in our power to help you to maximize your benefit. And you just want to be open and honest about that with them. I wouldn't say this is best case scenario, worst case scenario. Um, I wouldn't say, you have awful insurance and they're probably not going to pay anything. I mean, because that just makes the patient feel bad. It's like, here's the way it could go. It could go this way or it could go this way. And just getting the patient agreement to move forward either way. It's better to handle that in the front end than it is to have an issue on the back end. Now, um, I think that I think that let's look at what happens when we do need to do an appeal. So, what we have found is that when our clients go through the appeal process, it takes some time. But if they don't give up, very often they can get the benefit for the treatment that they provided. But they've got to go back and they've got to dig up some of this information, right? And hopefully the clinical note's going to be complete, and they can attach that. Um, they can provide maybe some different radiographs that show the bone level. That documentation has to be there in order for them to provide that. And then really get the patient involved, right? If it's something that you feel like there's no reason why the insurance company should not have provided benefit for this, have the patient call their HR director in their company, and talk to them. Say, look, this is crazy. I'm not getting benefit for this. This is a stated benefit, and that helps sometimes as well. Here's the thing to remember, though, is just because an insurance company doesn't provide benefit for a treatment, that does not mean that that treatment is not clinically, dentally, medically necessary. Okay, those are two separate things. If you see a statement on an EOB that came to you or to the patient that says anything close to this treatment was not necessary, that should be reported to your state insurance board. That was a real problem maybe about 10 years ago, and that got tightened up to where insurance companies stopped doing that. But I've seen it happen recently a couple times with some of our clients. And what that does is it undermines the patient's trust in you as their healthcare provider, and it's not appropriate, right? It's one thing if the insurance company says, "Hey, we're only going to provide benefit if the patient has, bleeding, 4 millimeters of attachment loss, and 5 to 6 millimeter pocket depths or greater." That's one thing if that's their plan outline. But if you're trying to be proactive with the patient and treat the disease earlier, you can communicate that with the patient. And but if the insurance company says it's not necessary, that's different, right? Their plan requirements are one thing, and sometimes they just are what they are. But that doesn't mean that what you're recommending isn't clinically beneficial or necessary for the patient. So just make sure those are two separate things, right? The insurance company is not determining, they are not to be determining what is clinically necessary for the patient.
And
Okay.
Rachel, real quick, one thing to
Yeah.
add with the appeals there too. We want to obviously make sure we're talking about like our clinical notes, that we have all the documentation and everything that's necessary. Your administrative team also needs to make sure that they're documenting the appeal process, right? When they sent
Yes.
everything back, the information that they sent back, and make sure that that is extremely detailed as well.
Mm-hmm.
Because if someone is sick or someone leaves the office, you need to make sure that you know the exact point as to where they left off and what they did and how they did it.
Yeah.
So just want to make sure that that's a little pro tip there too.
Yeah, yeah, good point. I would also say as soon as you get that notification that they did not provide benefit, call the patient immediately and tell them we're working on this. There's no reason why you shouldn't receive a benefit here. We're going to do everything we can, and we're going to do everything in our power to help you get the benefits that, we feel like you're entitled to. We cannot guarantee that, but we're going to do everything that we can. So be proactive. It's better for you to call them than for them to call you, right? Because then they know, oh, you're there on it. Okay. So as soon as you find out, give them a quick call and just let them know, hey, we're working on this. We're going to do everything we can to get this appealed. This is interesting. Patricia says, I heard the less you appeal, the less likely you win, meaning they label you as the office that doesn't appeal. So if I don't know if that's true or not. I don't know if anybody else has heard that, or had any anecdotal evidence around that the more you appeal, maybe it increases your chance of not having denials in that regard. I don't know the answer to that, but that's really interesting. So we included this from Practice Booster. Practice Booster is the insurance advisory service that we use. They're not sponsoring this event, but we recommend them. It's a live. You can see the CDT code is here. It's a live software. They update it frequently, and they give you tons of support, warnings, just things to look out for with certain codes. So just, read through those. And, for example, you were talking about reporting time. So number one, right, it's inappropriate to complete 4 quadrants of periodontal scaling and replanning in 1 hour. It's improper or misleading to report a quadrant equivalent. So I don't see this happening as much anymore, but when that 4342 code first came out, folks would kind of pull, well, this tooth and they'd bundle them in 1 quadrant code. So um, now we know that, we've got to make sure that we're using those codes appropriately. And they're based on the number of teeth per quad, not the number of teeth in the mouth. So they just give you a lot of really good detail and breakdown for that. Jennifer, was there anything else you wanted to add on this particular slide?
So one thing I'll say about Practice Booster that I have found, the website version is great. They update things frequently, like Rachel
Yes.
mentioned. It does come in a book form too, but the website is great. You can have it up on your admin team can have it up on their computers, your clinical team too. So that way it also gives them ideas as, um, what to put in their notes, right? Like what verbiage and things to use. So just super, super beneficial.
Mm-hmm. Yep, exactly. Okay. All right. So I do want to share with you all. Some of you have been through our Perio Protocol online bootcamp in the past. Some of you have heard of it. Some of you have never heard of it. So I'm going to do just a short little commercial, if you would allow me to do that. And then we're going to share a couple other things with you. So our Perio Protocol online bootcamp is a critical piece of our private coaching client's success. Every coaching client goes through that deep analysis, and then they go, as a team, they go through the Perio Protocol online bootcamp. It really helps them uncover areas within their periodontal protocols that they can enhance, elevate, refine, and also helps them establish a clear protocol if they don't have one in the practice. It opens up conversation with the team of where there are areas that they need to calibrate and helps them really get started on completing that standard of care. Once or twice a year, we open this up for purchase to everybody else, those that are not our private clients. And so that time is coming in June. So in the middle of June, we're going to open this up. We only open it up for about a week for purchase. And so if you're at all interested, go to periobootcamp.com right here. Go to this website right here, periobootcamp.com. You'll see a button on there that says, yes, I'm interested. And if you just join that list, then you'll be notified as soon as this is going to be launched. In fact, you'll get a notification a couple days before, and you'll get some special pricing and some additional bonuses and things like that. So make sure you get on that wait list for the Perio Protocol Boot Camp. You're in by no means obligated to purchase anything, but you'll just know when it's ready and you can take a look. You can take a look on this website at the details of the boot camp as well. They're all there. This is a self-paced boot camp. You have access to it for 12 months once you purchase it. And it's a great tool for bringing new team members up to speed, for getting your whole team on the same page with regards to, diagnosing, verbal skills, enrollment, all of the above, treatment planning sequence, and just lots of really solid information to help you develop a perio protocol and or refine a protocol that you may already have. So just wanted to share that the boot camp is going to be open really, really soon. So thank you for the interest in that. And then let's do this. Let's just open up any questions. Any questions for us? Any questions for us? You can drop them in the chat. You can raise your hand and unmute if you'd like to.
Any burning questions about appeals or denials? We have one that came in. Do you find it easier to get a patient involved to get appeals approved? Yes, we have found that it is easier to get the patient involved. Usually the patient has a little bit more pull with the insurance company because they are the one that's insured, versus the office trying to do that. So
Mm-hmm. Yep.
definitely helpful to get the patient involved and get them involved early too.
Yep.
Mhm.
I'm stuck on localized SRP and 4910 coverage. Okay, so often what we are seeing is that it often takes the patient having two or more quadrants of therapy in order for that perio maintenance to kick in. But here's what I'll say. Remember, we talked about incomplete treatment planning or undiagnosed disease. So what I would say is go back, and I am not suggesting that you do anything other than what is ethical and what is present with regards to disease. Okay. But what we see a lot of times is a practice will do localized scaling root planning and they'll submit the claim and they don't get the perio maintenance coverage. And the area that they treated, maybe there's like a 6 millimeter pocket in that one area. But then we look in all the other quadrants, there's bone loss visible on the radiographs, and there is bleeding, and there are 4 millimeter or greater pockets there. So my point is just make sure that all of the periodontal disease has been diagnosed and treated, because sometimes if we're just looking at one quadrant, there's actually disease everywhere else, but we're just picking the one area that's the worst, that seems the most obvious, and treating that when actually there's disease everywhere else. So, and if we would have treated that, then the patient's benefit for 4910 would have likely kicked in. So I would say, just really pay attention to that. What board did you say to report to? It's your state insurance. Jennifer, help me with this.
Your state
Insurance
dental.
commission.
Mhm, mhm,
Yeah, it's actually the state insurance commission,
mhm.
and it's called inflammatory language, right? So you contact them and say, hey, we're receiving EOBs with inflammatory language, and report that to the state insurance board, insurance commission.
Rachel, we have another one here. When sending claims for 4342, we've had some issues with with denials for not highlighting the entire quad.
Mm-hmm.
Seems some insurance want the entire quad in the claim form and specific teeth in our notes. So I
Yes.
had this issue before too. Um, your practice management system, it depends on the settings that are also set, what pulls in on the claim form. So I would just double check your settings on your practice management system too, so that way it's pulling in what you specifically need to report for that. Had that issue in a few offices before.
I would also say I kind of took that question a different way.
Mhm,
Is that is a similar answer to the one about the one quadrants, the one doing one quadrant of therapy. So perhaps what they're seeing is that there's disease in other areas in the quadrant, and it should have been coded as a D4341.
and not a 42.
Maybe?
Mhm,
Yeah. So maybe that's not the question, but that's kind of how I read it.
mhm.
What about fighting the downgrade from 4341 to 4342? I think, again, you have to be able to show that attachment loss and that bone loss. And we're sharing in this PPOB update that we're releasing in June,
Mhm.
some very specific training around how to read radiographs and what is normal bone on the radiograph versus what is bone loss. So we're going to be including that.
Mhm.
So you just have to make sure that you can document that bone loss on the radiographs. How do you get the hygienist to actually get the right x-rays and intraoral needed, plus those extra detailed SRP notes? Um,
I love this question.
Um, I think refusing to do intraoral photos, if that's your clinical standard in your practice, then how are you having, how is there a hygienist that's refusing that? I mean, look, I know I'm being sarcastic. I don't mean to be that way. Okay, so let's start over.
Standard of care. Go
Let
back
me
to the
start
standard.
over.
No, but go back to
Go
the
back to
standard.
the standard of care. Do you have a written standard of care?
Mhm.
And here's the deal. When you do the standard of care, this is not a dictate that comes like the dentist shows up with it one day, or the office manager, or even worse, shows up with it one day and is like, this is how you have to practice dental hygiene. That doesn't really work, right? it really is more of a collaborative effort of, hey guys, let's get together and let's get really clear on what our diagnostic standards are. Like what is the data that we're including and why? And let everybody have a voice in that, whether they agree with it or not, allow them to have a voice so you can kind of talk through that. Our recommendation is if we're recommending any treatment, we have to have at least one intro photo, right? I mean, if you're doing a crown, right, on a tooth that has a big filling, you have to have a photo. You have to. So it's required, right, if we're recommending treatment. And then if you have a written standard of care that everybody's agreed to, and yet it's still not being withheld, then you go back to being withheld, then you have to go back to that standard of care and say, how can we support you in collecting this information? Um, Diagnostic X-rays are a basic standard for for any clinician in your practice that's taking radiographs, is that they be of diagnostic standard, right? That's the definition of the bite wing, is that we can see the bone level. And if we can't see the bone level because there's bone loss, right? Then we do a, yeah, absolutely, Gina, I've had the exact same thing. If we can't see them on the bite wing, then we do a vertical, right? Or or we find a way to combine it with, a PA or something like that if there's so much bone loss. Yes, my doctor would not do an exam unless there was an IOP on the screen. Absolutely. And
Mhm.
so it didn't take me very many times, right, to figure that out. Um,
Yeah.
Thank
We
you
had
for
a
that.
question, Rachel, about why do some insurances care how much anesthetic is used?
Uh,
I think every insurance company is completely different.
mhm.
So really it's our job to understand how we can get the patient the benefit that they need. So that's where, the certificate of coverage that Teresa Duncan was talking about comes into play, exactly what you need to report on the form to get them coverage the first time. So just, important to kind of look at that because every single one is completely different and every plan is different. So
Yeah.
um, yeah, important there. Do you find it better to also include post-op and pre-op x-rays for SRP patients?
I don't know the answer to that specifically. I think it can't hurt. We have some clients that take them just to check their work.
Mhm.
Yeah. I want to address a couple things here. There was a long question here, Monica's question. I think this can address several different things here. So even though so regardless, so this is addressing also the question about the insurance company, that
Mhm.
their benefits are basically saying this, they're gonna, how did she word it? It was about
Because
substandard
we're
care.
finding that even with submissions of correct documentation, x-rays, periocharts, etc., we're still getting denials when treating early stages of periodontal
Yeah.
disease. Insurance often rebuttals. There's not enough bone loss on the x-ray.
Yeah.
The
So
delta has.
again, they can set their benefit limits anywhere they want to set the benefit limits, okay? They can say that the patient has to have stage 3 or 4 in order to provide a benefit. That does not mean that we shouldn't be recommending treatment at stage 2, okay? So what I would say is this is where that proactive conversation comes in. So you might say something like, here's the thing. Your insurance company, in order to provide benefit for this level of care, they require that you wait until you have much more bone loss and much more dramatic disease. I don't feel comfortable waiting to that point to tell you that you have active disease and recommending treatment. Here is how this could go, right? It could go one way is that we provide all the documentation and your insurance company decides that you have sufficient level of, bone lost to provide benefit. The other way it could go is that your insurance company is not going to provide the benefit until you've lost a lot more bone, which you can never get back, right? And so, either way, we're still recommending this treatment now because this disease and this infection can be stopped now to where you don't get to that point where you have that level of bone.
Mhm.
So, here are the options. Here is your responsibility either way. What would you like to move forward with this treatment? When can we get this scheduled for you? And see what the
Rachel,
patient says.
Rachel, we got a question in here regarding if insurance companies are using AI to review treatment. They
Yep.
absolutely are. We know that. And that's
Yep.
why if an office is using AI, when they are submitting their claims, they tell them that they can submit the radiograph that has the AI on it, but they have to submit the original radiograph as well, the one that has not been altered by AI.
Hmm.
So that way their systems can run and do everything in the back end too. So that can definitely help in your claim process if you have AI, but want to just make sure that you also share the original radiograph.
Hmm. I would also remember appeal. I
Mhm.
would do at least one appeal, right? Because you just never know. You might get in front of somebody different. You might have some additional documentation. I would say with regards to the gingivitis therapy question, yes, we do have clients who have found that they can get benefit for that. Again, it requires the same type of documentation. Now, doesn't require bone loss to be visible, but if somebody is turning in a perio chart but yet there's no bleeding charted on it, there's no sign of active infection. So I would just go back and like really look at those things and see like, do we have all of the information that they may not even be asking for it, but that we know is necessary. And that is correct. D4346 is there needs to be moderate to severe generalized gingivitis, and that is 30% or more of the mouth that bleeding is documented. And yes, intraoral photos are amazing for that. I would agree with that.